Buenos días a todos. Good morning, everyone. Bienvenidos a una nueva sesión general del Hospital Universitario Marqués de Valdecilla. Esta vez, como las sesiones al final de cada mes, es una sesión patrocinada por el IDIVAL. Y quiero aprovechar para transmitir que estamos muy satisfechos desde la Jefatura de Estudios en el apoyo que recibimos del IDIVAL para mantener una formación de alta calidad en nuestro hospital. Yo creo que es un vínculo buenísimo y de verdad estoy muy satisfecho de cómo estamos trabajando en conjunto. Hoy tenemos una sesión con un ponente de primer nivel mundial, el profesor Alexander Heazell. Thank you for coming, Alexander. Es un Senior Clinical Lecturer de obstetricia y director clínico del Centro TOMI de Investigación sobre Mortalidad Fetal de la Universidad de Manchester. Es una primera figura mundial. Yo creo que es un privilegio para nosotros tenerle hoy aquí. Va a hablarnos sobre un aspecto que consideramos que también es muy importante, que es la asistencia y el cuidado de los pacientes perinatales y los esfuerzos que ha habido para reducción de mortalidad. Y seguro que va a ser una conferencia brillante. Thank you for coming. It's a pleasure for our hospital to stay with you today, and I hope the lecture will be fantastic for us. Thank you.
Buenos días. Muchas gracias por invitarme a hablar hoy. That is the end of my Spanish. So thank you very much for inviting me to talk a bit about how we can reduce stillbirths and neonatal deaths and our experience of doing that in the UK. The first question that I think is really important to address is, why did we need to try and reduce the number of babies dying? In the UK, you can see on the left that the stillbirth rate in the UK was 24th out of 49 high-income countries and 19th out of 38 in Europe. So we were performing worse than we would want to. And in the left-hand column is the annual rate of reduction since 2000. And you can see that actually the number of babies dying was only going down at 1.4% per year. So we were making very slow progress. If you compare to Spain, actually the stillbirth rate is very similar between Spain and the UK. And actually the annual rate of reduction in Spain was just under 1%. So again, Spain is making similar sort of slow progress to the UK. Now, the other problem that we have, so in this map of the UK, red is bad, red is above the national average, green is good, it's below the national average, and yellow is about in the middle. And you can see that there is wide variation throughout the UK. There are some areas of the UK that are much worse than others. And this is, a lot of it is tied into deprivation, so poverty. Where I work in Manchester is about there. So we are red. So we need to make some progress. And the other reason for doing this is that I think for a very long time we felt that stillbirth was just one of those things. There were some babies that died, there was nothing we could do about it. But actually we've begun to realise that the effects of stillbirth are very long lasting. They are very costly, particularly to mental health and well-being. So you can see that even within the clinic there are increased healthcare costs when a baby dies. It has a negative effect on us as staff. There are problems with family breakdown, and ultimately it can affect people's earnings, they have maternity and paternity leave, and healthcare expenses. So the UK government in 2015, they read all of these statistics and they decided their policy was to reduce the number of stillbirths, neonatal deaths, maternal deaths and brain injuries by 50% by 2030. So that's our government decided that. And everybody was very shocked and thought, how on earth are we going to do this? And just while we were thinking that, they sped it up to 2025. So then everyone did another really big sort of shock. So how do we go about reducing the number of babies that die? Well, the first thing that is really important is to understand the risk factors and why babies die. And we're very lucky in the UK to have national perinatal audit. So we review cases and we find where there could be areas for improvement. We need to do research for how we can get messages better, to develop interventions, to implement the interventions, and then see whether they prevent stillbirth. So we carry on going round this loop to see if we can improve our outcomes. So perinatal audit is really, really important. Fairly consistently, confidential inquiries show that 1 in 4 stillbirths could be prevented with the right care. And that's not just in the UK, it's in multiple different settings. And the important thing is it enables us to understand how we can develop improvements locally, because I can't tell you what is going to work in Santander, you can't tell me what is going to work in Manchester, because we work in different places. What you can see, this is a graph from New Zealand, and you can see since perinatal audit began, national perinatal audit began, there was a year-on-year improvement in the number of babies that were dying. So these are just some examples of confidential inquiries from the UK. So in 2013, we looked at 85 cases of antepartum stillbirth, so babies that died before labour. 2 of the main problems were missing babies that were abnormally small and also not responding when a baby wasn't moving normally. In babies that died due to problems in labour, you can see actually 80% of cases different care might have prevented their baby's death, and in particular guidelines weren't followed when monitoring baby's heart rate in labour, so we missed opportunities to intervene. And lastly, we know that twin pregnancies have a higher rate of stillbirth and neonatal death, and you can see here again in the red that there was problems relating to care in almost 2/3 of cases when care related to the mum, shown in red. We also know there's other important risk factors. So women who are not white in white dominant populations, migrants, women who are have low income or low education, all of those women have about a 2-fold increased risk of having a pregnancy loss. And that can be due to not accessing care, so not having enough antenatal care. It can be due to things like smoking and obesity. Obesity is I was going to say it's a big problem, but that, you know what I mean. It's a growing problem in the UK. Now about 1 in 3 women are overweight or obese in pregnancy. So what the health system did to try to improve things is to make this thing called the Saving Babies Lives Care Bundle. And the Care Bundle is a way to bring our best practice guidance into one place and to try and help people implement it. So it started off in 2016, and there were 4 elements. So there was reducing cigarette smoking, better risk assessment and surveillance for babies' growth, raising awareness of reduced movements, and effective monitoring of babies' heart rate during labour. Then, when we had evaluated the first care bundle, we realised we also had a problem with preterm birth, so they added a 5th element, which was about reducing the risk of preterm birth. And last year, they added another one, which is about managing women with pre-existing diabetes, because in the UK, the stillbirth rate in women who have diabetes is about 4 times higher than everybody else, and it isn't going down. It's basically just staying the same. So it's really important when we roll out a project like this at system level that we see whether it works. We can't just take it for granted that something's going to have the effect that we want it to have. So we need to ask 3 questions. The first is that, is the care bundle being adopted? Are the individual hospitals doing what we want them to do? The second question is, when the hospital says they've adopted it, are the midwives and doctors really doing it? And then, when the doctors and the midwives are really doing it, does it work? So there are those 3 questions. So we need to collect different information to enable us to understand that. So to answer the middle question, we collect something called process measures. So measures that help us understand whether people are doing the right thing. And then ultimately, in the red, what we really want to understand is, does it improve the outcome? So we evaluated the care bundle, and we did lots of different things, but I'm going to present 3 of them to you today. So I just want to talk a bit about the outcomes, the process indicators, and also looking at clinical practice guidelines. So what does best practice look like? So we actually evaluated 19 maternity units in the UK. They were distributed throughout England. We had data on over 467,000 births, nearly over 1,900 stillbirths. We did an audit of over 1,000 pregnancies, nearly 600 babies that were born small, and we heard from over 2,200 mothers and 1,000 health professionals. So there was it was a big piece of work. So the first question, as I said, is the care bundle being implemented? So here, if units were implementing less than 50%, they are red. If it's between 50% and 75%, it's orange, and more than 80% is green. So you can see at the beginning, before we implemented the care bundle, units were doing some things, as you would expect. You know, we've never not monitored babies' heartbeats in labour. We've never not looked for growth restriction. But you can see it's mostly orange. People were doing bits of what they should be doing. By the time we get to the middle, when the care bundle was rolled out, about half of units are now green. More units are doing what we want them to. And that was sustained through the next 2 years. So there was evidence that hospitals were able to implement the care bundle, but it was different depending on the different elements. So you can see on the left, so that was stopping smoking. So you can see that was quite challenging. And that was because there was a policy change in the UK that meant that lots of the stopping smoking services had their funding taken away. So just at the time that we really wanted to send people to stopping smoking, they took it away. So, and I'm sure maybe your health service is more joined up than ours, but it was a good example of, the right hand didn't know what the left hand was doing. Growth restriction is also really challenging, and that's because of the extra scans. And so people had to find that extra capacity. But actually monitoring in labour and awareness of baby movements was much better implemented. So did we see any change in outcome measure? Well, the really encouraging thing is actually over the time period of the intervention, the stillbirth rate fell by 20%. So you can see there was a gradual reduction over the period of time in the stillbirth rate. And the annual rate of reduction, which remember was only 1.4% during this period, fell to 5% per year. So we think, now we've got to be careful because it's a before and after study. We can't, it's not a randomised controlled trial, but we did see an acceleration in our stillbirth reduction in the UK. The factors that were linked to stillbirth was hospitals, the specialist hospitals had higher stillbirth rates than the general hospitals, but we would expect that because they're looking after the sickest mums and the sickest babies. Women who were more wealthy had a lower stillbirth rate than women who were deprived. So again, if you are working in a very deprived area, you have a higher stillbirth rate, and also cigarette smoking. So that's continued to be a challenge for us. However, there were other things that changed over that same time frame in the UK. You can see that preterm births, so births before 37 weeks, went up by 6%. See if I can make this work. There we are, 6%. Our emergency caesarean section rate went up by 10%, and our inductions of labour went up by 20%. So really significant impact on the service we deliver. Also, the average number of ultrasound scans per pregnancy went up from 3.5 scans per pregnancy to 4.5 scans. So really a considerable increase in our ultrasound resource. And you can see that more clearly on this picture. So we were doing more ultrasound scans, but it did have a positive effect. So our detection rate for babies that were small went up from 1 in 3 babies, so we used to miss 2 in 3 babies, to over 50%. So we were detecting over a half of small babies. And actually, one of the only things that related to the stillbirth rate was the number of scans we did. So the more scans overall that were done, the lower the stillbirth rate. Women who came with reduced movements, you can see that the majority of women got the leaflet, but actually when mums came, only half of them, our standard checklist was used, and only 3 out of 4 women had a CTG when they came with reduced movement. So there's still work to do there, but the majority of women felt that they now received the right amount of information about monitoring their baby's movements, and 96% of them did. So that seemed to change behaviour. When we thought about how much money this cost to do, we added up all the different elements, and it costs a lot of money. It costs £94 million a year to deliver the care bundle. However, you've got to remember, in the UK, there's 750,000 births a year. So it actually works out as £140. So what's that? Probably about €175, something like that, per pregnancy per year. So it is deliverable if the government want to resource it appropriately. Staff, when we asked staff, almost everyone felt that the demand for ultrasound scanning had increased, which is not surprising because we showed that it did. There was also increased inductions and caesarean sections over the same time period. However, most staff felt that the number of stillbirths was either going down or hadn't changed. There were very few that felt it had gone the wrong way. We use, again, I'm not very familiar with the system here in Spain, but in the UK we're quite reliant on our national guidelines, and we like national guidelines. And by and large, staff like the idea of guidelines because they believe that they means we offer women high quality care, and they also mean we're offering standard care. So we're not deviating, and we don't have 80 different ways of doing the same thing. We've got trying to do it one way. However, there were some important problems. People said that a lack of time meant that they couldn't use the guidelines, or that they couldn't read them because they were, that long and they didn't have time, or they couldn't actually do all the things the guideline says because they didn't have the resources to do them. So it's all very well somebody like me writing a guideline when I work in a teaching hospital and I've got lots of scanners and everything else, but that doesn't necessarily help somebody in a smaller hospital. When we looked at the guidelines for individual maternity units, so in the UK what happens is we have a national guideline, and then doctors or midwives from an individual hospital sort of translate that into how it works in their unit. And so we had 75 different guidelines from the 19 hospitals, and you can see we had most of them covered the elements we were interested in, but 6 of them were out of date, and another 8 had no review date at all, so we couldn't tell whether they were up to date or not. When we looked at the quality assessment, so we used a tool called the Agree To tool, which is a standardized way of seeing if clinical practice guidelines are good. So you can see at the top, we say, firstly, this should be 100. If it's perfect, it should be 100. So you can see our scores were about in the middle. The best was smoking cessation. The worst was reduced movements. We're quite good in domain 1 up here, saying what the guideline is for. But when we talk about how we're going to actually deliver the guideline, we're really bad. So in terms of saying, if I'm going to do an audit to see whether we're doing it or not, we don't say what our audit standards are. We don't say what we want to be able to do. And actually only 1 in 20 guidelines were recommended for use in clinical practice. 72%, if we'd modified them, would be good, and 16% we said you shouldn't use this because it's not accurate. So there were some quite important errors. And again, to try and just convey this, green is it completely agreed with what national guidance should be. Orange is it agreed in part, and red was it either just wasn't there or it said the wrong thing. So you can see there's quite a lot of red, basically. So what tends to happen is people look at national guidelines and then say, well, we can't do that in our unit, so they just leave it out. Or they say, oh, I don't agree with that, so they change it. So what happens is what you want to happen gets watered down by the time it actually happens. So what can we conclude from our stillbirth rates? Well, the first thing is to say that we definitely need to do something about them. It's something as a maternity service that we want to get better at. That when you make a care bundle, it is implemented by the majority of units. Everybody improved. But there was variable implementation. And that has to do with resource. It has to do with whether or not we agree sometimes on the ground. And we have shown that there was a real increase in the rate of improvement of stillbirth over time. But there was changes in other important secondary outcomes too. Clinical practice guidelines are highly valued, but they're often not very good quality, and they often don't contain all of the recommendations they should. So we're always playing catch up a little bit in the UK. We then are trying to evaluate the second care bundle. So they changed it and added the preterm labour. So we are now evaluating the second iteration of the care bundle. And we've done that using pretty similar ideas, but this time tried to use our national data and also different approaches to speak to staff and service users. So again, you can see we've got participating units all over the UK. The dark pink are babies, the most senior neonatal units, so the sickest, earliest babies. The green are big hospitals but don't have those big neonatal units. The blues are really small general hospitals. So you can see there's a variation of who we've got. So this time we've done 29 maternity units in England, and we aimed to get 2,000 surveys in all of the sites and then conduct 40 to 60 follow-up interviews. So what can we see? Well, the first thing is to say that in the UK, if you look at on the left is the number of births. So actually, our birth rate, it sort of hit a peak in about 2012 and then has gone down since then. And there's also quite big variation in different regions of the UK, which is what the colours are. You can see the stillbirth rate. The national stillbirth rate is in black in the middle of all of those colours. And you can see in 2020, we hit our lowest ever stillbirth rate in the UK. But sadly, 2021, in the middle of COVID, it went up. We're waiting for our 2022 data to help us understand whether the COVID going up was COVID, or whether, and it was just a bump, or whether there are more problems that we need to address. The other thing that's so overall, if you go from 2015 to 2021, there's been a 25% reduction in stillbirths, even allowing for that uptick. And if you look at intrapartum stillbirths, there has been a 33% reduction. So a really significant reduction in the intrapartum stillbirth rate. Trying to evaluate anything using routinely collected data is a challenge, but trying to evaluate anything using routinely collected data in a pandemic is madness. It's really, really hard because it's very difficult to understand what was your intervention, what was COVID, and what was the interaction between the two. So you can see here, if you look at the 2021 data, the orange are the stillbirths in women who were COVID positive. So if you're optimistic and say, well, that's our bump in the road, the blue has actually continued to fall. But we don't know. We're going to have to. So 2022 data should come out about now, and we will know much better. If you break the stillbirths down by gestation, the stillbirths that the care bundle is really trying to prevent are the stillbirths at term, which are the orange line. And then you can see the preterm stillbirths are in the other colours. And the interesting thing is, in COVID, if you look, actually the orange line continued to drift downwards, and it was the preterm stillbirths that went up. And I know you were speaking yesterday about the COVID study that you did. In our experience, the women who had specific COVID-related deaths were very often preterm. It was that population rather than the term stillbirths. So I think that gives cause for optimism that maybe we are continuing to prevent those deaths. So when we've looked at the smoking reduction in pregnancy, so element 1, which is reducing smoking, we moved to a system where every woman, instead of us saying to them, do you smoke? Because some of them said no and they should have said yes, we use a carbon monoxide detector so we can detect the smoking. And interestingly, despite concerns that people wouldn't take the test, actually, if women were offered the test, almost all of them took the breath test. And it was done on multiple occasions. And so you can see here that we had 10% of women were smoking to some extent at the beginning of their pregnancy. And that's very typical of our UK population. Increasingly, younger women are using e-cigarettes, which we don't know whether they're bad or not, because they're too new. You can see that actually, if women were smoking, 1 in 3 were referred to a stop smoking service. If they were referred, 41% went to the smoking cessation service, but encouragingly, 50% of them had stopped by the end of their pregnancy. So there is a reduction. Now that's much better than it used to be. We used to have a smoking at time of delivery rate of about 8 to 9%. And I think smoking is something particularly here, if those women stop smoking and stay stopped smoking, that is better for their lifelong health as a whole, not just for their baby or them in pregnancy. The other changes, it's really important that we look at the other outcomes, not just whether a baby dies. You can see that in the UK, about 1 in 8 babies are admitted to the neonatal unit after birth, and it keeps going up. I think it's because we pay our baby units per baby that they admit, so they like the money, so they keep admitting them. But what you can see is the red line is the most serious admissions. That's neonatal intensive care. So actually neonatal intensive care is very steady. We're not really admitting more babies to intensive care. More encouragingly though, so if you look at the right-hand graph, the green dotted line at the left is when we implemented Care Bundle 1. The solid green line in the middle is Care Bundle 2, and then the two brown lines are the lockdowns in COVID. So what you can see before the lockdowns in COVID, the green line at the top is admissions for asphyxia, and they fell and have stayed lower. And the red line is admissions for babies that are growth restricted, and they have also fallen. So at the bottom, as a sort of control, is the babies admitted with congenital abnormalities, and you can see they basically haven't changed. So we're not admitting sort of fewer babies, but we do seem to be reducing the compromise from asphyxia and growth restriction. So that's a positive sign. So in summary, trying to get evidence on these national programs is really challenging. We have lots of data sources. A lot of maternity units have switched to having electronic patient records, which is really good news. But every hospital's electronic record is slightly different to the next hospital. So when you just say to them, can you give me your electronic data? They say, yes, that's really easy, but then you have to make all of the electronic data line up because you're comparing apples and oranges. As I said, we've got the background of the COVID pandemic, which makes everything more challenging. The data that we have on process measures suggest that we're getting better. And the outcome measures, as I said, we think stillbirth might have been affected by direct and indirect effects of COVID, but other outcomes, in particularly including hypoxic ischemic encephalopathy, do show an improvement over time. So thank you very much for giving me the opportunity to share these data with you, and I hope that that's been helpful. I think what the take-home message for me is that when we're trying to have these national programs, and this is equally relevant for local ones as well, is that we need to make sure that we build in evaluation, because trying to do it afterwards is really hard. And if we want to have a health system that learns, then we need to sort of build it into what we're doing, and that we have a quality improvement cycle that says, what are our results? What changes do we need to make? Have the changes made what we want them to do? And also that our medical and technical solutions don't provide the complete solution. So it's really important to remember, what about the effects of deprivation? What about social determinants of health? There is only so much that we can do as doctors and midwives and public health physicians to try and do that. I'd just like to finish by acknowledging Kate, who is the project manager, who has done a huge amount of work in bringing this together, Steve, who is our statistician, and Liz, who is the health economist. And none of research like this is done by individuals, it's done collectively. So I'm very grateful to them and all of the stakeholder organisations who have helped us along the way. And thank you very much.
Thank you for your excellent presentation. We have now time for questions. Is there any questions in the audience? Any comments?
First place, thank you so much for coming to us. We would like to know what information do you give to the women when we come with reduced fetal movements?
Yeah. So I better go back to this microphone, otherwise we won't hear. So the information that we give, so we've got a leaflet that goes to all women during their pregnancy, and we were very careful. I will just show it to you. Hang on, because it's very. One of the things that's really important is that we had it translated into lots of different languages. So if I can, hang on, here we are. So that goes in everybody's notes, and then through this there should be, there we are, there should be Spanish, I think. There we are. And so that goes, so everybody by 28 weeks should have that leaflet. And then we have a triage unit, sort of 24 hours a day, and women would come in. And then there's a checklist that units we provided to help units, make sure everyone has a CTG, they have an ultrasound if there's risk factors for growth restriction, and that they should be advised to come back if their baby's not moving normally again. So you sort of, the idea is to try and standardise that. Now, only half of units were using the checklist, so we're hoping when we look at that this time, it's a little bit better. Oh.
Thank you very much for your presentation. Concerning the COVID, what do you think about, we need to compare pre-COVID and post-COVID, and I think we need a window of years. For instance, comparing 4 years before the 2020 and 4 years after. Because probably the peak of the pandemic is not going to be the real situation. It has a post period that the effect is still there.
I think that's a really good point, and I think it's going to take, because different countries and even different regions of different countries did things at different times and released restrictions at different times. It's really complex, isn't it? There was no sort of one response to COVID at a specific point in time. And we also don't know what about the sort of non-medical effects of COVID. So one of the things that, the whole thing was really pretty stressful. And we know that stress can adversely affect pregnancy outcomes. So things like birth weight are lower in women who have significant stresses like the death of another child or death of a family member. We know that can have an adverse effect on birth weight. So it might well take, I think you're right, we need a big window either side, and it's not just, I don't think you can just correlate it like at the time of the waves. So I don't think you can say, well, look, there was lots of COVID in March 2021, so that must be when the bad outcomes were, because it may be that the bad outcomes could be 9 months after March 2021. So I think it's going to take us a long time and a lot of data to disentangle it all, I think.
Any more questions?
Thank you very much.